Welcome to our session today. This is the second session of the oxygen therapy and critical care, the case-based series. And we are going to be discussing on the diagnosing hypoxemia and pulse oximetry. I would like to introduce myself. My name is Kevin Raphael. I work with Assist International. I will be helping in facilitating this session. Also with me, we have Alvin and Rahul from the ECHO India team. They will be helping facilitating the session and troubleshooting any difficulties anyone might have. After saying that, I would like to welcome Dr. Ananya Abate, the Hub Director for this program, ECHO program. I will let him introduce himself and the panelists and take over from this point. Dr. Ananya, please welcome. Dr. Ananya, please welcome to the session. You can introduce yourself and the panelists, and you can take over from here.
Okay, thank you very much. Can you hear me?
Yes.
Okay. So thank you, Kevin, for a nice introduction. I am Ananya, anesthesiologist, and I'm working in the Kurambasa Specialized Hospital, and I'm directing this ECHO Ethiopia Oxygen Therapy and Critical Care program. And thank you, Assist International and Stanford Medical University and ECHO for organizing this session. It's gonna be a 12-module session. In the last month, we have run one of the session. It's about it was about oxygen. COVID-19 triage, how to make triage patients at emergency OPD. Now today we'll be discussing about oxygen therapy and critical care, and also diagnosing hypoxemia and how to use Pulsox in oxygen therapy and critical care module. So I would like to invite our panelists today, Dr. Unatu and Dr. Mahalit. I'm sure they have joined the session so far. So I will start with Dr. Unatu, if he can introduce himself.
Thank you very much, Dr. Ananya, for the opportunity. I am Dr. Unatu, anesthesiology from St. Peter Specialized Hospital. And thank you very much for the opportunity, all the organizers and the panelists.
Thank you, Dr. Unatu. So, Dr. Mahalet, can you please introduce yourself? Okay, probably Dr. Mahalet haven't yet joined our program, maybe internet issue or something. So she will join us in a while. So as many of you have already entered the room, we have to proceed with our planned session. So can you hear me? And is it visible here?
Yes, we can hear you. We can also see your screen.
Okay, thank you.
I've also shared the link to the direct page in the chat box to you.
Okay. So through the Learning Resource Center, we will be going to, diagnosing hypoxemia and pulse oximetry. And we need to log in. So sorry, I think it's taking too much time to join from here.
Can I share the screen for you, Dr. Ananya?
Let me try one more time. Yeah, network is bad as well here. Yeah, I think now I got the screen, right? So can you see the screen now? With
yes, we can. Yeah.
Okay.
We can see now.
Thank you. So we have 65 participants so far, and we'll be running the session now. So as you may remember, last week we have started with a man, 57 years old, who presented with chills, weakness, and a dry cough. And we'll continue with the same scenario, but with different objectives. So what are our today's practice change objective? At least you can see on the orange background, okay? So by the end of the session, we'll be able to understand how to use a pulse oximetry during the COVID-19 pandemics. So as in the previous session, the objective is not just to understand or know, recognize things, but we want you guys after this session to go back and practice based on the knowledge change you have acquired from this session. You will be able to understand and recognize pulse oximetry latency at the end of this session. We'll select rank oxygen delivery devices by FO2 delivered, and we'll be able to use also Livebox triage tool, and we'll see what Livebox triage tool looks like and how to select delivery device and how to titrate also oxygen therapy, when to escalate and de-escalate oxygen therapy. And also will be you'll be able to assess your facilities non-invasive oxygen delivery devices and type of oxygen supply at your facilities. And you'll also interpret data obtained using pulse oximetry, and you'll be understanding what's the limitation with pulse ox, and you'll be able to understand how to use pulse oximetry safely, like without causing damage and without also transmitting infection. So you will be knowing about how to clean and maintain pulse oximetry devices. So, sorry. So let me give you, the case scenario and the case updates of what we have seen on the last month. So it was a 57-year-old male patient presenting with 4-day history of chills, weakness, and cough. His wife is a nurse and she tested positive for SARS-CoV-2 3 days ago. And his SpO2 level reached 89% at home. So his wife sent him to the emergency department. At the hospital, the patient was screened for COVID-19 risk factors and isolated from other patients, and is wearing face covering. You and the nursing student are wearing PPE for contact, droplet, and airborne precaution. The patient admits he is short of breath with moving and eating, but he denies fever, shortness of breath at rest, loss of taste or smell. He states he has been less active and staying in bed. So his vitals are heart rate 95 beats per minute, blood pressure is 95 by 52 millimeter of mercury, respiratory rate is around 24 breaths per minute, saturation of oxygen is 89%, temperature is 36.5. Now, with this vital sign in the history and your exam, you recognized right away that the patient is hypoxic, and you started him on oxygen by nasal cannula at 5 liters per minute flow, and his SpO2 initially improved to 90%, 97%. So keeping in mind this scenario, so how do you think is a pulse oximetry being used in COVID-19 pandemic? So you can write on the chat box. These are this is the first discussion point. So how is pulse oximetry used in COVID-19 pandemic? So I will see your chat, and you can write in your chat box. I'll give you 2 minutes. So anyone who wants to try? Did you get the question?
Dr. Ananya, I think there are several responses in the chat.
There are? Okay, I have to see that, please. Sorry. So, essential diagnostic tool to follow patient's oxygen status and improvement, and to check if any disconnection alarms. The other says immediately if patient has respiratory symptoms, including cough, shortness of breath, or if COVID suspected. To check for hypoxia, it should be individualized for patients not to cross-contaminate. Oh, so a lot of descriptions and attempts, and all of them are, right? So it's as a part of vital signs. Somebody says it's as part of vital sign. Some patients don't look like they have hypoxia. Yes, right. So we have to use Pulsox. So many of you have attempted it, correctly, and pulse oximetry is useful in diagnosing hypoxemia, especially in COVID-19 pandemic, where patients could be hypoxemic but silent with no any clinical sign. So previously, in previous eras where we don't have pulse oximetry abundantly available in African and setting, we used to diagnose hypoxemia, clinically. But the trick with COVID-19, those patients who are hypoxic may not be having symptoms, and that was some of the things you were raising. But some of you also mentioned that by using pulse oximetry, we would know the degree of hypoxemia and will decide on what mode of ventilation. So let's see some of the materials we have here. So here are materials from prepared by Lifebox and partners, and on how to use pulse oximetry for in COVID-19. So I'll prefer to go with running a video, how to use pulse oximetry.
This video shows the use of a pulse oximeter in the context of the COVID-19 pandemic. Severe COVID-19 primarily affects the lungs.
So it's audible, right, Kevin?
Yes, it's audible. We can hear.
My video is audible, okay.
Measuring oxygen saturation is essential for deciding when to use precious oxygen resources during the pandemic. Oximeter is used to measure oxygen saturation and can help identify severely ill patients who should be hospitalized and receive oxygen therapy. Please note, available oxygen, flow rates, and administration practices will vary according to local protocols and resources. Make sure you know what kind of oxygen therapy is available in your institution, how it can be delivered, and what local guidelines are in place. Do you need to measure your patient's oxygen saturation? You will need to decide whether your patient should have their oxygen saturation measured. To decide, you will need to ask 5 questions. 1. Does your patient have a fever? 2. Does your patient have a cough or difficulty breathing? 3. Does your patient have an increased respiratory rate? 4. Does your patient have any emergency signs, such as obstructed or absent breathing, severe respiratory distress, central cyanosis, shock, coma, convulsions, or uncontrolled vomiting? 5. Is your patient being admitted as an inpatient? Fever. Any known fever over the last 14 days is an indication to measure oxygen saturation. Cough or difficulty breathing. Any cough, difficulty with breathing, or shortness of breath over the last 14 days is an indication to measure oxygen saturation. Difficulty breathing can be any abnormal breathing pattern, including but not limited to breathing too fast, too slow, too deep, noisy breathing, labored breathing, or any pain or discomfort associated with breathing. Increased respiratory rate. An increased respiratory rate is an indication to measure oxygen saturation. This is a little more complicated than the other reasons to measure saturation, as normal respiratory rate varies. Let's spend a little time here reminding ourselves of abnormally high respiratory rates in different age groups. In adults and children 16 years of age and older, a respiratory rate of 22 breaths per minute or more is abnormal. In children 5 to 15 years of age, a respiratory rate of 30 breaths per minute or more is abnormal. In younger children from 1 to 5 years of age, a respiratory rate of 40 breaths per minute or more is abnormal. In infants 2 to 11 months of age, a respiratory rate of 50 breaths per minute or more is abnormal. In neonates and very young infants up to 2 months of age, a respiratory rate of 60 breaths per minute or more is abnormal. Any patient who has an increased respiratory rate should have their oxygen saturation measured with a pulse oximeter. Emergency signs. Emergency signs are an immediate indication for admission and resuscitation, including administering oxygen therapy. Resuscitate, administer oxygen, and measure the patient's oxygen saturation if any of the following signs are present. Severe respiratory distress. Signs of severe respiratory distress can include obstructed or absent breathing, head nodding in younger children, nasal flaring, grunting, usually in younger children, tracheal tugging, intercostal retraction or inward pulling of the skin between the ribs during inspiration, and deep lower chest wall indrawing or inward pulling of the skin below the ribs during inspiration. Other emergency signs include poor perfusion or weak pulse, which is a sign of shock, coma, convulsions or seizures, or vomiting all food and drink and medicines. If your patient is being admitted to the hospital with suspected or confirmed COVID-19, or for any other respiratory illness, use a pulse oximeter to check oxygen saturation, along with vital signs. For patients who are under simple observation and do not have low oxygen levels, you should be checked at least every 6 to 12 hours, depending on illness severity. How to measure oxygen saturation. When using a pulse oximeter to measure oxygen saturation, remember to use the correct probe for your patient. Young children in particular need appropriately sized probes. It may be difficult to get a reading in critically sick patients. We recommend 2 strategies to make it easier to measure the oxygen saturation in younger children below 2 years of age. First, using the big toe, as this allows the child to sit comfortably in the caregiver's lap and be comforted. Second, you may allow a breastfeeding child to feed during the measurement to improve cooperation. You may have to wait 30 to 45 seconds for the pulse oximeter to display the pulse rate and oxygen saturation readings. If your patient is very unwell and you cannot get a reading, administer oxygen and call for help immediately. How to use the oxygen saturation to decide next steps. You have now used a pulse oximeter to measure the oxygen saturation of your patient. Depending on the result, you will decide to administer oxygen or plan how to monitor your patient without oxygen therapy. If the patient's oxygen saturation is 94% or higher, and they do not have any emergency signs, you do not need to administer oxygen at this point. In this case, you should follow local protocols for COVID-19 testing and isolation. Remember, all inpatients should have their oxygen saturation measured with their vital signs every 6 to 12 hours. If the oxygen saturation reading is less than 94% or emergency signs, administer oxygen via nasal prongs or standard oxygen face mask and check the saturation every 2 to 5 minutes. The next oxygen therapy decision is made depending on the outcome of 15 minutes of oxygen therapy. After 15 minutes of oxygen therapy, check the oxygen saturation again with your pulse oximeter and check whether the reading is 90% or above or less than 90%. If the oxygen saturation is 90% or above, continue standard oxygen therapy as you are doing and monitor the patient. If oxygen saturations rise to 96% or higher, reduce the oxygen flow rate. Oxygen saturation and vital signs should be measured at least every 4 to 6 hours while oxygen therapy is ongoing. If the oxygen saturation is less than 90%, oxygen support should be maximized. Oxygen flow should be increased where possible. Other measures include using a face mask with an oxygen reservoir for adults and a head hood for infants. Once again, oxygen saturation should be checked every 2 to 5 minutes. Check oxygen saturation using a pulse oximeter after 15 minutes of maximal low-flow oxygen therapy. If the oxygen saturation is 90% or above, continue maximal oxygen therapy and monitor the patient. Oxygen saturation and vital signs should be measured at least every 4 to 6 hours while oxygen therapy is ongoing. Oxygen saturation should be maintained between 90 and 96%. If the oxygen saturation is less than 90% on maximal oxygen therapy, refer for ICU admission where available and escalate respiratory support where possible. Oxygen saturation should ideally be monitored continuously. Oxygen saturation measurement is the best tool you have to decide when to use and maximize precious oxygen resources during the COVID-19 pandemic. We thank you for all that you are doing for your patients during these difficult times. Oxygen saturation measurement is the best tool you have to decide when to use and
Okay, I think the videos were very informative, and you have seen how pulse oximetry can be used in COVID-19 pandemic. One thing is to diagnose hypoxemia. The other thing is, after diagnosing hypoxemia, what amount of oxygen with what delivery to be given is well discussed. Maybe I would like to show you as well one of the tools we have from Lifebox. that is a pulse oximetry COVID-19 decision-making tool. And this tool is produced by different physicians in collaboration with Pulsox and other organizations. Now, yeah, so the tool is here. I'm not sure if you can see from this font, but they have, the tool to diagnose COVID-19, and we have seen it in our last month's session. But to make a decision on when to start oxygen therapy, with what amount, and so on, this tool has been developed, and it was on April 2020, last year, that means. And as it's described in the video, so the first thing, whether to use Pulsox or not, depends on, the indication. So these are indications to apply pulse oximeter and try to see if the patient is hypoxic or not. The indications are like having fever within the last 14 days, cough or shortness of breath, and higher respiratory rate. Higher respiratory rates definition depends on the age of the patient. Like for neonates, greater than 60, but for adults, greater than or equal to 22. And if these symptoms are present, then it's indicated to apply pulse oximeter to know if the patient is hypoxemic or not. If there is an emergency sign like obstructed absent breathing, severe respiratory distress, central cyanosis, shock, coma, or convulsion, now this is a right indication to put the patient on oxygen and at the same time measure saturation using pulse oximetry. And after, measuring, if your initial SpO2 level or saturation level is less than 94%, then it's an indication to start the patient on treatment with oxygen therapy. In emergency signs, and without even seeing the saturation, you have to right away start with oxygen. So the initial oxygen should be started with nasal prong as low flow with 5 liters per minute in adults and 1 to 2 liters per minute in children. And, you have to continuously ask patients and see the response. If the patient is not responding, then you right away increase or titrate up your flow or change the oxygen delivery device. But if the saturation is okay, then you need to recheck after 15 minutes, okay? It's, we are in a resource limited setting and Pulsox might not be readily available. So you might be using Pulsox for several individuals. Because of that, monitoring every 15 minutes can be acceptable, but the ideal thing is to leave Pulsox on the finger and follow the patient continuously. But if there is an emergency sign, 15 minutes is a bit larger, so you have to re-evaluate patient in 2 to 5 minutes, okay? And with this management, if the saturation is not, in acceptable range, that's above 90%, then you have to go to, more oxygen delivery device that can deliver much more fraction of inspired oxygen. That is like face mask with a reservoir. And again, you have to recheck every 15 minutes or 2 to 5 minutes. So this is something which was described in the video as well, okay? In case if the patient is showing improvement with your management, then you can admit the patient in the ward and monitor saturation every 4 to 6 hours, okay? So this is the minimum. But as I said, continuous monitoring is something recommended. And something you shouldn't forget about, and what this tool tells us is in pregnant ladies, your saturation is like 92. So in a pregnant patients, you want to maintain saturation between 92 to 96%. whereas in other patients, the lower cut point of 90 to 96 can be used. Whenever your saturation reaches above 96%, this is the time where you start to de-escalate your oxygen therapy. So I think so far it is good. Maybe I'll check if Dr. Mahalet joined our session. She was having some internet problem. So if she's with us, I would like to ask her if she has any experience, regarding Pulsox use and how it really changed the management in COVID-19 pandemic, or even before the COVID-19 pandemic in our setup. Dr. Mahalet, are you around?
Yes. Okay, thank you, Dr. Ananya. Yeah, so I totally agree with what has been said up to now. So I'm sure everyone can agree that pulse oximetry has significantly changed the way we practice medicine. So, for example, when I was a resident, and not resident actually, when I was a student and an intern, I remember a time where pulse ox used to be a rarity. It was only found either in the OR or in the ICU, and we had to rely on other signs like respiratory rates, signs of respiratory distress, cyanosis, all these things which are very unreliable. And even if there's hypoxia, it would indicate hypoxia when it's very late into for starting management. So it was a very big challenge. I mean, we didn't have pulse oximetry, and now with this portable and easily accessible and relatively cheap pulse oximetry, we are using it in the emergency for triaging patients, and for early recognition of hypoxia, we're using it at the OPD. We're using it at the normal wards for periodic check. Like someone said, it's the other vital sign of for managing any patients. And we use it. Of course, we are still using it in the OR. It's one of the essential tools and part of the WHO checklist. And also in the use in the PACU for recovery patients, we have significantly changed the way we manage our patients, and we have improved our patient outcomes and improved our early treatment and overall management of patients who are hypoxic and who are on oxygen.
Yeah, thank you very much, Dr. Mahalet. Yeah, so we can see how pulse oximetry really changed our management in diagnosis and treatment of hypoxemia, and also especially in COVID-19 pandemic. So now let's proceed with the next discussion point, which will be, after starting oxygen therapy, let's say you use Pulsox, you diagnosed hypoxemia, and you put a patient on oxygen therapy. And how long after starting oxygen should the saturation of oxygen increase? So this is our second discussion point. So I'll give you 2 minutes, and you will be writing as usual in the chat box. Yeah, either Sal Dempsey said after 2 to 5 minutes, the SpO2 improves. Very good try. So any more? I'm waiting for some more people to participate. You know, the question is very important because all of us will just administer oxygen and want to see a change in saturation of oxygen. So within how many seconds or minutes are we expecting a change to occur? And in here, there are, two concepts. One is within how many seconds can a pulsox detect the result. The other thing is after oxygen reaches into the lung and then to the blood, where it can be detected at the periphery from the tissue. So someone says 1 to 2 minutes, 1 to 3 minutes. Dr. Hussein says it depends on the severity of the underlying lung condition, within a minute, right? Yeah, 3 to 4 minutes. So I can agree with all of you, The considerations are now, latency. When you say latency, within how many seconds or time frame will the pulsox can detect a pulse and measure a pulsox? Measure so oxygen saturation is one thing. The other thing is oxygen from the atmosphere or oxygen source reaching to your lung, diffusing through the alveolo-capillary membrane, diffusing into the blood, and reaching to the periphery or the capillaries is one of the other things to consider. So 3 to 4 minutes, 1 to 3, someone says a minute, and depends on the severity of the illness. So I think most of you have tried to come up with a tangible answer. At this interface, I would like to invite one of our panelists, Dr. Unatu. If you have any, experience or literature review regarding this latency, within how many seconds or minutes we would expect improvement in oxygen saturation.
Thank you very much. I have seen the trial and everyone has tried. Actually, it depends on the patient condition. Yes, it's right. As a OR and critical care practice, we have to know that the resaturation response time and desaturation response time. So once we put a patient on oxygen, there is latency, both to show the decline in oxygen and to show the increase in oxygen saturation. So large literature reviewed. So in patients who have hypoxia and during bag mask ventilation, there is a delay about 23 seconds for probe in the head and about 29 or more seconds in patients who have finger probe. So the clinical implication of this result is whenever we are bagging a patient, if there is decrement in oxygen, it doesn't mean that really the saturation is decreasing. So we have to correlate our clinical judgment. The same is true for desaturation time. So in patients who have been on oxygen, if there is any discontinuation of oxygen or failure to ventilation, there is a delay to detect desaturation again below 90%. So it's estimated to take 100 seconds, which means about 1.something minutes to detect the decrease in saturation of oxygen. And if it is a forehead probe, it's later, it's about 90 seconds to detect. So that practically we are also witnessing that patients are, the time lapse is clinically significant.
Yeah, thank you, Dr. Unat. It was a nice information and also from backed by literature. Okay, this is something I read also from a journal of critical care. I have done this research regarding how fast patient desaturate or how fast they kind of increase oxygen by administering, and also comparing, the different modalities of pulse ox, like the one which is put on the finger or the one which can be put on forehead. The mechanism of detecting oxygen saturation is different for this group of SpO2 available. But for looking through this literature and also from our experience, what we can say is it varies between individuals, as so many of you were saying, and it varies with the type of pulse ox you are using and the quality. But in general terms, we can say there is latency around 30 seconds. Some even may say up to 45 seconds. So 30 to 45 second latency is something expected. So after applying a pulse ox, you have to wait. You have to have these patients to wait 30, 45 seconds to see accurate reading. This is the time the pulse oximetry takes to detect the pulse. But a change in oxygen saturation really depends on the patient's condition, but most of the time it's not more than 2 minutes, okay? So if your patient, after starting oxygen therapy, you see no change in your oxygen saturation, then that is the time when you want to try, I have to escalate my oxygen therapy. So in some patients with a very good lung, a cause of hypoxia is some other things like hypoventilation and so on. Even within a few seconds, oxygen saturation may improve. But in patients like COVID, ARDS, and so on, it takes time for oxygen to improve, but average, we can take something 1 to 2 minutes. So most of you have guessed almost very close to that number. Thank you, Dr. Unat. It was a nice insight. I think you have got the message from this discussion point. Now, I would like to take you to the third discussion point today. You are seeing a picture of different oxygen delivery devices on the screen. Now, I want you to order these oxygen devices in terms of FiO2. It can deliver from least to highest, okay? When we say FiO2, it is fraction of inspired oxygen. That means the concentration of oxygen in the air molecule that's being delivered by these delivery devices from our oxygen source. It could be cylinder or oxygen concentrator. So please rank among these oxygen delivery devices, okay? The first picture is like face mask, simple face mask, then venturi mask, then nasal prong, then the fourth is face mask with reservoir. So I can give you minutes. So from Emmanuel 3124. So 3124 means nasal prong, 31 face mask, then venturi, then mask with reservoir. Okay, very good. Nasal cannula, simple face mask, venturi, face mask with reservoir from Hussein. Very good. 3124, Amar Gabri, nasal prong, face mask, venturi mask, reservoir. Yeah, almost all of you are telling us 3124. That's correct and right. So let's see. So, in order to, understand this well and memorize, it's good to use, oxygen wall chart. Last time, I'm sure I have shared this as well. We'll revise it today again. So the oxygen wall chart is something developed by Pulsox and some partners, and it tells us, what different oxygen delivery modalities we have and how much FiO2 it can administer and what will be the flow rate. So most of you have got correctly. So you say the nasal prong is the least to deliver small FiO2 as compared to the other. Yes. So nasal prong can be used in adults and children at a rate of 0.5 to 5 liters per minute. If you administer oxygen above 5 liters per minute through nasal prong, then you are going to, one, irritate the nasal mucosa and predispose for bleeding. The other thing is you waste much of the oxygen because much of the oxygen won't be getting into the nasal cavity to the lungs, rather would be to the atmosphere. So the fraction of inspired oxygen that can be achieved is something 28 to 40%. You can even get lower FiO2s like 24% if you are using a low flow like 1 liter or below that. So with 1 liter increment in using nasal prong, you are expecting to increase the FiO2 level by 3 to 4% from the atmospheric level, which is 21%. The next to that, maybe, which is not mentioned, which was not seen on the previous picture I have showed you, is a nasopharyngeal catheter. It's usually used in infants and children. So at a rate of 0.5 to 2 liter, and we can achieve fraction of inspired oxygen up to 60%. Okay, because now we are administering oxygen much close to the tracheal opening, and it will going to be more concentrated as there is less dilution from the atmospheric air. When you take the nasal prong, there will be dilution of oxygen by the atmospheric air as it's far from your trachea and the lungs. So whenever you have infant, child, nasal prong, saturation is not improving, then you can consider nasopharyngeal catheter as an option. Then comes face mask, as you say, is used in adults as well as children. The flow rate with face mask is 6 to 10 liters per minute. If you administer something below 6, then it can lead to, dead space ventilation or rebreathing because it has got some dead space around here. So it can be filled with carbon dioxide and can be rebreathed again. So it's not advisable to use a lower rate of oxygen using a face mask. So something 6 to 10 liters is recommended. And the maximum FiO2 you can achieve is 60%. Now, when you add a reservoir to the simple face mask, it will become mask with a reservoir. Application is in adult children, and now you have to use larger rate, 10 to 15 liters per minute, because now the oxygen requirement is very high. So when you tightly fit this mask to the patient, then you can achieve FiO2 up to 95%, okay? That's why you said mask with a reservoir bag can deliver a high amount of oxygen. Now, something you may not be really familiar with could be venturi mask. It's not widely available in our setup or in any other low middle income countries. But with some donation and so on, some of you may be able to find it, or you might have already encountered it. The good thing about venturi mask is you can adjust the inspired oxygen that can using Venturi mask by using a different colored connectors from the oxygen source to the mask, and it can deliver up to 4 to 15 liters per minute of oxygen with maximum oxygen saturation of 60%. Okay, so the advantage over mask could be, you know what fraction of inspired oxygen you are delivering to the patient. With mask, you can't determine that. Then incubator tent head box is something used for neonate or infant, and currently it's not recommended by WHO because wastes oxygen. One thing, it can predispose neonate for hypercapnia, and it needs high flow rates in order to avoid hypercapnia. So it can waste oxygen, but at times where you cannot increase oxygen saturation, with whatever we said before, you may use head box or incubator tent. So having this oxygen chart at your setup on your wall, somewhere that will be visible for everyone practicing at emergency ICU, OR, or wards, then it's to select between oxygen delivery devices and to know how much effort we are delivering. So I'm going back to previous screen. No, not this one, sorry. I'm so sorry. I'm so sorry. Yeah, to my previous slide. So I think so far you are good with the lesson. So we have done with, the third discussion point. Now we'll go to the fourth discussion point of today, which is about when do you need to escalate oxygen therapy support. So can you write it in the chat box, please? Okay, when oxygen support is less than 90% after 15 to 30 minutes of oxygen therapy, if we can't achieve the target saturation, patient deteriorating, okay. Good, 2 more tries. Yeah, I think it's enough because we have discussed it also in a previous question. So as most of you or the participants are saying, we need to escalate oxygen therapy when saturation is not able to be rising while we are administering oxygen above 90% in non-pregnant and above 92% in pregnant adults. And, the frequency of measurement is, as you know, if there is an emergency sign, it's 2 to 5 minutes. For other follow-up is every 15 minutes, but, to see if there is a need to escalate or not should not be above 2 minutes. So within 1 or 2 minutes, patient is not responding to our oxygen therapy, you have to escalate your oxygen, okay? And our goal is between 90 to 96%, or 92 to 96%, depending on whether there is adult patients pregnant or not. So thank you for your participation. Now, in the interest of time, I will proceed updating the case. Remember this 57 years old man who's isolated and because of his symptoms like calf chills, and he is also desaturating, and you started oxygen therapy. Now, when you perform your history and physical exam further, you discovered that he has polio, diabetes mellitus, and HIV, and inguinal hernia repair in 1988. And his medication is heart, insulin, long-acting, and preprandial. And on his family history, mother and father is diseased because of different reasons. Mother has hypertension, father had emphysema, and he has 1 young sister, 2 children, all are healthy. And he works in construction. He drinks alcohol, 2 alcohols 3 times per week, and he does not smoke. He does not use illicit drug. But he has, left facial drop from childhood polio. Otherwise, he has no any positive on HPI. So let's say you have a nursing student with you, and he asks you about what did you plug the oxygen into? Where does the oxygen came from? So he is asking you about the source of oxygen. Where is the oxygen coming from? So I want you to list out the different type of oxygen supply. And among those different type of oxygen supply, which one does your facility use? Okay, so 2 sets of questions here now. What are the different types of oxygen supply? Where are we getting oxygen from? And which does your facility use? Very good, Emmanuel. So he said concentrator, cylinder, and pipeline. Excellent. Is there anything else? From atmosphere, okay. So quite interesting. So from atmosphere, there is oxygen. Yeah, 21% oxygen. Also from cylinder, concentrator, pipeline, e-cylinder. These are small cylinders attached to the anesthesia machine. Concentrator cylinder. Oxygen plant, okay, from Matusala, very good one. So it could be an oxygen plant. Yeah, wall source. Yeah, almost excellent. So these are the commonest, source of oxygen supply in our setup, but it could be different in other setups as well. So at this point, maybe let me invite our colleagues, panelists. So Dr. Mahalet, can you maybe tell us what your facility is currently using as oxygen source?
Okay, thank you, Ananya. So, like most of our audience, my hospital, we also use the oxygen cylinders and the oxygen concentrators. So our hospital, it does have the setup for pipelines, but unfortunately we haven't used it. I'm not sure if it was in use when the hospital was established like some 50 years ago, but at least for the past 10, 15 years, it hasn't been on use. Another thing, maybe in our ICU, we started a system like where we kept the cylinders in one room and connected it to the series, to the manifold, and supplied the beds for our ICU. So this was a system where we used. So we still use the cylinders, but it was through the pipeline that we got it to the individual patient. So this was actually quite good because, you know, like we didn't have to transport this big bulky cylinders to patient's bedside. It also minimized the interruption, you know, when we run out of one cylinder up until a new cylinder is connected to the ventilator, there's always this gap. So again, these kinds of things we did manage to avoid it, but again, it had its downside. So in case, like, or if just in case all the cylinders run out of oxygen, then we were faced to have, you know, the whole ICU patients, the whole ICU beds all run out of oxygen at the same time. So this was one of the big downside we saw in that system. Otherwise, we also use the oxygen concentrators, which are portable, and as long as electricity is available, they're good for most of our patients who only need oxygen by nasal pumps or face masks. But unfortunately, of course, we cannot use it with our ventilators and our in other high flow requiring equipment. And even in the OR, again, we still use the cylinders, unfortunately. Yeah, so this is my experience from my hospital.
Yeah, thank you, Dr. Mahalit. It's a good explanation of your setup. And as you said, most of our hospitals in Ethiopia lack high oxygen delivery sources like oxygen plant or liquid oxygen, but most have oxygen concentrator and cylinder. And you were telling us, you know, the downside of this cylinder and oxygen concentrator. And, you know, for a reliable source oxygen plants, liquid oxygen might be really necessary, but they have also their own downside, like, you know, high cost, needs a lot of infrastructure and associated high pipeline pressures and so on. But at least the minimum we can do is, as you said from your experience, having oxygen in series, you can see on the picture as well. Just placing them in one room in series and attaching with manifold pipeline system and just delivering it from one side to the other. This can avoid, you know, transporting oxygen and using cylinder and, you know, some of the dangers that can occur by moving cylinder here and there. So yeah, thank you. So Dr. Unatu, can you tell us, you know, your institution, your setup, what oxygen support source you are using?
Thank you, Dr. Ananya. The practice in Peter is also the same. So we use oxygen concentrator and oxygen cylinder. But a couple of months ago, we have completed a central source oxygen. I don't know, but soon it will come into practice so that we may use central oxygen, which may be distributed throughout the ICU or in some major areas. Otherwise, we use concentrator and cylinder. In one of the private center that I practice, they use two big cylinder connected with the anesthesia machine. The one serves as the cylinder, so that whenever you have a completed, when you finish one cylinder, the other cylinder will come into play, but it is manually. So we can take this in some of the government hospital Thank you.
Yeah, so very good. So that means the place you are working, St. Peter, is planning to have a oxygen plant, oxygen producing plant.
No, it's from the central source. Yeah.
Yes, central source
Pipeline,
with oxygen
pipeline
cylinder.
intra-hospital distribution, man.
Yeah,
The
so
pipeline
okay.
intra-hospital
Yeah,
distribution
that's
network
even
is
something
central.
better, right? So having an oxygen source through the pipeline system from a central source, from a big tanks, it could be, or from cylinders arranged in series. But oxygen plant is something which really needs, a lot of investment, and I think we're heading to that. So from this discussion, I want participants to go back to your institution and look into, what different oxygen source modalities your institute using and what you can improve in the future, depending on your oxygen consumption and oxygen requirement. Which of these oxygen source modalities are important for your setup, you can decide. And maybe at the end of this session, I will share the mechanism how you will know your oxygen consumption and your oxygen requirement. And in order, it helps you, in order to define what oxygen source is really important in your setup. So far, we have discussed on important issues with oxygen therapy and pulse oximetry use. So there are some action items I would like you guys to do. These are listed in the orange box here. So I would like you to survey your facility to understand oxygen supply options available. You have to list the number of each of the following, like oxygen cylinder, oxygen concentrators. You have to note if your facility uses pipeline gases, and you need to understand who maintains the oxygen supply system. Survey your facility to understand oxygen delivery devices available, like simple mask, venturi mask, mask with a reservoir. And you need to understand by just doing this survey who orders, maintain, and sterilize medical equipment. And I have shown you, the Hypoxia trash tool before, so you have to download that. I will share it also in Telegram. It will help you in managing hypoxic patients. And not only download that, but post it in areas where you are caring a critical patient, like emergency wards, ICU, and the like. So these are some of the action items based on our discussion. Okay. Now let me go to updating you about the case. Okay, this same man. So you put a pulse ox, as you said, and you diagnosed hypoxemia. And now let's say your pulse ox suddenly alarms, and the reading is what you see on the picture. So what's wrong with this patient? You can write on the chat box. So here is the pulse ox. Here is the pulse ox waveform. So you see the pulse ox reading here, and the pulse rate below like 55, and the pulse ox reading is 83. And this is the waveform. So this is a pulse oximetry interface. Now what's wrong with the patient? If there are students beside you, like a nurse, and if the nurse asks you, what's happening? What shall we do now? The pulse ox is also alarming. Okay, let me see the chat box now. I think pulse oximetry placement is inappropriate. Okay. The waveform is not correct. The pulse may loosely attach, not attached well, not attached well, not attached well again. It could be artifacts, maybe cardiac rhythm abnormality. Okay, I think you have tried well. Excellent. So maybe Dr. Mahalets, can you comment on this? You have seen most of our participants are saying this is an incorrect reading because of the pulse ox waveform is not good. So can you comment on that? You know, this is a common experience in our setup.
Yes, so everyone has appropriately, correctly mentioned most of the things. So always when we see a pulse oximetry reading, we have to make sure that it's an accurate reading. So we shouldn't be rushing to staff management, or we shouldn't be given false reassurance if just by reading the numbers. So one thing we always have to make sure is that we have the pulse oximeter has a good, strong pulse signal. So we have to have a good waveform in order to accurately say that it's the correct reading. And always we have to factor those things that most of the audience mentioned. So like if your patient is shivering, if he's moving his hands, for example, if the probe is not correctly placed, or if the light is not passing through the body part attached to it, whether it's the ear or the fingers, we also have to make sure that there is adequate perfusion in order for the pulse ox to have an accurate reading. There has to be a good perfusion of the periphery and a good arterial pulsation. So again, anything which might compromise is like decreased cardiac outputs, patients who are in shock, who are vasoconstricted, or who are hypothermic. So all these things we have to consider, and we have to use our pulse oximetry correctly, and we have to make sure that we have a good pulse signal. Thank you.
Yeah, thank you, Dr. Mahalet. Yeah, this is one of the commonest things we are seeing. You know, people, they put pulse ox on the finger, see the reading, and only focusing only on the reading, they may say, oh, patient is hypoxemic, but the reality is the pulse ox may not be accurately detecting the reading. Because of that, you can know whenever you have a bad waveform. So for accurate measurement, there needs to be a good waveform associated with pulse ox application. Okay, so I would like to show some, you know, video here, but I'm having trouble here. It's not allowing me. Let me see. Not this one actually. So I would like to show you, you know, how to interpret pulse ox. There is a video here, a little bit technically difficult. Yeah, this one, okay. It should be running soon. So most of the things covered in this video is something Dr. Mahalet was telling us. So those factors which can affect your pulse ox reading, like, you know, peripheral vasoconstriction, because of hypoperfusion state or because of coldness of the patient, or use of nail polish, or in pigmented skin, or use of dye, intravenously injected dyes like methylene blue, or presence of bright lights surrounding. It could be from OR light or sunlight coming through the glass. These conditions really affect your pulse ox reading, and you have to know those factors. I think my video is not running, so yeah, it's okay, and we can go back again to our session. So I think most of the things are something and the video is all about what I said and Dr. Mahalet was telling us. Whenever you want to know the accuracy of the pulse oximeter, you have to see a good waveform. Some pulse ox do not have a waveform or do not produce waveform, but they can show a signal strings. So signal strings has to be good. So when you say pulse ox, it measures, the name is pulse ox. So there needs to be pulsatile flow of blood in order to detect the oxygen saturation. So whenever the patient's capillary pulsation is weak, poor, so you see on the pulse oximetry the signal strength is very bad or poor or absent. And if there is a waveform, the waveform will not be nicely tall. So in that case, you have to say, oh, this reading is not accurate. And it's not only to say this is not accurate, but they have to check, the hemodynamic status, is the patient hypovolemic, how is the cardiac output, and things like that. So, for your practice action item, please list factors that can interfere with accurate pulse oximetry values so that you can, memorize and know them. And always recognize, pulse oximetry latency. We said after applying pulse ox, you don't see the oxygen saturation immediately. It takes some time. So wait some time until 30, 45 minutes, seconds to have an accurate reading, okay? Now, let's go back to this patient case, and let's say the pulse oximeter had fallen off the patient's finger, and you had your student reposition the probe, and now the SpO2 reads 95%. So this means, previously the pulse ox probe was not, appropriately placed on the finger. That's why it was not reading accurately and was not detecting the pulse, okay? So now it just fallen down and your student puts it back in a proper position and the SpO2 reads 95%. So most of you has guessed it that it was not appropriate reading. Now, when we see the probe has fallen off the patient's finger, then you have to think of how do we properly care for pulse oximeter? When we say how do we care, then it includes like preventing it from falling down, and it can cause when it's falling down in the floors, and you have seen that pulse ox are fragile, the probes are fragile, and they may get injured. The other thing is, in a COVID pandemic, when you are using one pulse ox for multiple individuals, you need to clean them in between. So how do you safely clean them? Take 2 minutes to respond to this discussion point or question. Yeah. So I'm looking into chat box. You can write it in short, how do you clean it? How do you care for pulsox? Yeah, we have to be careful not to turn the cable, not to break the machine. Yeah, these are, quite expensive equipments and needs to be cared. Also, Semacho said cleaning by alcohol by using clean gauze. That's good, correct. So, yeah, disconnect from monitors and clean by alcohol swab and wait it to dry. Yeah, before using it, let it dry by itself. Very good participation here. So I'll invite here Dr. Una to can you tell us your experience, how you care for pulse oximeter and how do you clean them between uses,
Okay, thank you very much. Yeah, as you know, pulse oximetry is very delicate and sensitive, especially part is very sensitive. The battery, the microprocessor, and the adapter are also very sensitive. So the general care that we should take care of the pulse oximetry is at the time of use and during process, package, and post-use. So during cleaning, we have to swab it with alcohol or water soaked with soap. These are the practice that we are doing, and that is the practice that should be done. So we have to, in cleaning, we have to avoid using acids, base, immersion into water, barakina, and other cleaning agents. So the other thing that damage patient pulse oximetry is heater. So in a hospital where I practice, it's very cold. Last week, we have lost one pulse oximetry. So that unfortunately, it was near to the heater. So that excessivity is one of the factors that damage pulse oximetry. The other thing that we should take care of the pulse oximetry is during insertion and removing from the monitor, we have to be very gentle and we have to avoid kinking of the cables. And during residency, what I have been witnessing is falling down of pulse oximetry. So this is also the other care that we should avoid. It has to be suspended to the place where it's guaranteed that it's not falling down, or if it is with a microprocessor in the main monitor, we have to make sure that it is properly fixed. The other thing is to avoid pressure. So whenever we are applying plaster and other stuff, and when we are putting the portable pulse oximetry in our locker, we should avoid any excessive pressure on our pulse oximetry. These are the general care that we have to do, and this is my experience, the one which is falling down in the excessive heat. Thank you.
Yeah, thank you very much, Dr. Renatu. Yeah. So this is really from your experience. So you have finished your residency recently, and you have a good memory of how things are, especially in the Kurambasa Hospital, where we have a lot of patients to be managed, and pulse oximetry is rampantly used here and there. And you have seen how many pulse ox we lost within a year time because of inappropriate care or handling in a rushing environment. So some of the tricks you told us here are very, very important to, somewhat improve the shelf life of our pulse oximeter. Thank you. Here, I have a video from Pulsox, and it shows, it's a 1-minute video, and it shows about how to clean.
It is essential that you gently clean the probe and cool it with medical alcohol. Small amounts of 70% alcohol-based hand rub will also work, but should be applied sparingly. It's important to keep the LED and photodetector clean. Please also remember to wash your hands, following proper protocol between patients. The oximeter should be wiped down regularly, using common detergent and non-corrosive disinfectant, such as those used in hospitals. Be aware that many kinds of detergents must be diluted prior to use. The oximeter case and screen can be wiped with a lint-free soft cloth or a sponge moistened in detergent. While cleaning the oximeter, be careful not to spill liquid onto the instrument, and do not allow any liquid to spill inside the oximeter. When wiping the side panel of the oximeter, be especially careful to keep liquid away from the cable and the outlet.
Yeah, I think the video is also informative. So as Dr. Unat was saying, you can use alcohol, but be careful not to use too much alcohol and get into electrical system of the pulsox, which can damage the pulse oximetry. So the other important thing is you can use any detergents available in the hospital, but it has to be diluted. If you have to use let's say sodium hypochlorite solution, then it has to be diluted into like 0.1% solution. Using that as a solution, you can really wipe out the pulsox monitor part as well as the probe. And each time when you are cleaning your pulsox device, you have to remember also to wash your hand before touching the pulsox, and also after cleaning and touching the pulsox. I think this is the message, and please take care of your pulse oximetry, as it is a delicate structure. Now we are about time, and we are about to finish our discussion. And this was our practice change objective, and I think we addressed that well. Now I'm sure you have understood how to use pulse oximetry during COVID-19 pandemic. Also, you recognize that there is pulse oximetry latency, and as many of you are participating in the ranking oxygen delivery devices by effort to delivery was made, then you have to use now live box triage tool in order to titrate oxygen therapy and in order to choose oxygen delivery devices. And now what is left is, now at the end of this session, you have to assess your facility, available oxygen delivery devices, available oxygen support at your facility, and assess your oxygen consumption rate and come up with a plan whether to improve this oxygen supply or not. Now, the other objective is you are able to interpret data from oxygen pulse oximetry, and you have understood the limitations. And Dr. Mahalet really was dealing with artifacts and the limitations well, and I'm sure most of you know that by now. And you know by now how to clean and maintain pulse oximetry devices, and we'll share you as well some materials which can help you in your setup, and you can develop your own institutional guidelines or protocol on how to clean those medications. The pulse oximeter. So these are the major points and the key points of today's session. So do you have any question or comment? You can put it in the box. So the key topics today was about oxygen supply, oxygen delivery, oxygen therapy escalation, using pulse oximetry for triage and understanding limitation of pulse ox. The end of session. So let me see if there are questions in the chat or some comments. Yeah, so while waiting, if there are any question or comments, I would like to wind up the session by thanking our panelists, Dr. Mahalit Taddese, who's an anesthesiologist and a cardiac anesthesia specialist in Black Line Hospital, and Dr. Unatu from St. Peter Hospital. I really like to thank both of you for taking part in this session, and all who participated in this session. We have more than 80 participants today, and you are actively participating, and I would like to thank you. And those of you who are supporting, assisting, this program to run. Kevin was with me, assisting technically and also opening the session. Thank you, Kevin, and also the Eco India group for technically assisting us, and the Eco Projects, Assist International, and Stanford Medicine University for organizing all this session and providing also materials to be customed in our local setup and to be presented like this. So thank you, everyone. So I have one maybe suggestion, I'm not sure, in the chat box, which says patient in shock have extremely hypothermic and pulse ox will not detect pulse. Is there any indirect way to measure oxygenation level? So yeah, it's a very good question. Now, in case of shock or hypothermia or patients like hemodynamic instability, it's very difficult to detect with pulse ox. But hypoxemia can be diagnosed either clinically or using more invasive methods like arterial blood gas analysis. And from arterial blood gas, you can know the arterial saturation level, which is much more accurate than the pulse ox reading by itself. But in the setup where you don't have this ABG analysis and pulse ox is not working, then you have to rely on your clinical strategy to know if the patient's hypoxemic or not, like having higher respiratory rates, patients in respiratory distress, waiting, okay, or pathologies that will otherwise suggest patient could be hypoxemic, like absent breathing or gasping kind of breathing. Patients in shock by itself is also indicated for oxygen therapy. So using your clinical judgment, you can administer oxygen. So it's one of the limitations with pulse ox is such low cardiac output states. And yeah, it was great lecture. Thank you. And we have other invasive, yeah, Dr. Hussein was also saying we have other invasive techniques like ABG. So thank you, Dr. Hussein. So I think we are 5 minutes past our end time. So to respect our time and participants' time, I'll wind here. If Kevin has something to say as a closure, and please say something, and we will be meeting after a month for another topic.
Thank you, Dr. Ananya, so much for such a good learning session, and thanks to all the panelists as well. Just a few things to say to close this session today. Remember that you can visit the Learning Resource Center for the presentation, slides, and recording as you saw during the presentation. This site also includes many additional resources, quizzes, case exercises, and video. And this is the link to the Learning Resource Center. The link to the video recording and the Learning Resource Center will also be shared to you after the session by email. For those of you who haven't joined, you can join our community Telegram group by scanning this QR code here, or you can message assist at the number shown there. And we thank you so much for participating in this session. If you have any questions, you can email at echo@assisinternational.org. And remember to join us for session number 3 next month on Tuesday, July 27th, the last Tuesday of the month. And we are going to be discussed on our frequently asked questions roundtable on oxygen therapy and critical care. So until then, I wish you all a good time and see you then. Bye.
Thank you very much. Bye.